Good afternoon, everyone. My name is Garrett Schmidt, and I am the managing editor for ACO Exhibit Hall. And I'd like to welcome you all to today's webinar, which is a panel session by CareJourney called What You Can Learn from VA-DOE's COVID-19 Mortality Risk Model and the Emerging Trends like Telehealth. And we've got an exciting list of panelists and a great discussion for you today, which we'll get into in one moment. A couple items of note before we get started. All attendees today have joined in listen-only mode, so you don't have to worry about muting your mic. That's been done for you. Today's webinar is being recorded, so you will each have the opportunity to rewatch the session and or share it with colleagues after the fact. And I will send each of you an email after the webinar with a link to the recording, and there will also be a place where you can download the slides. And we hope that you will share that with colleagues as well. And finally, we would like to hear from you. So during the webinar, you will be able to submit questions at any time. You don't have to wait till the Q&A to our presenters using your attendee control panel in the question area. So not in the chat area, but there's a specific question area for that. And we will answer as many of those as we possibly can during the Q&A session at the end. And these questions are also being recorded, so even if we're not able to get to yours today, we will make sure to follow up with an email afterwards to get to your inquiry. All right, so without further ado, let's jump into the presentation. Our presenters today, our panel today rather, is going to be moderated by Anish Chopra, who's the president of CareJourney and the first US CTO under President Obama. With special guest John Peloit, Director of Performance-Based Payment Policy Group, CMS, and they are going to begin with a little conversation, and then we're going to dive into the panelist group. Our panelist today is Raj Shrestha, COO Community-Based Care and President and CEO of Castell and Intermountain Healthcare. I hope I pronounced that right. David Klebanis, COO of Palm Beach Accountable Care Organization. Mike Kerouac, CEO and co-founder of Precise Telehealth. Dr. Amy C. Justice, who's a CNH Long Professor of Medicine and Public Health at Yale University, and is also, which is not pictured here, but Joseph King, who's the Chief of Neurosurgery at West Haven VA Medical Center, and also Associate Professor of Neurosurgery at Yale School of Medicine. So at this time, I'm going to hand it over to Mr. Chopra. So welcome.
Hey, thanks, Garrett, and thanks for everyone for participating today, and John in particular for helping us kick everything off with some opening comments. Our intention today was to share a bit about, almost in the world of agile research, the ability for Medicare ACOs to benefit from the great work done at the VA in developing a pre-existing condition COVID mortality model. I'll share more about that when I get into the discussion with Amy and Joe. But today we're going to learn a bit more about their work and the implications for ACOs, and particularly with our panel, how ACOs have really turned on, if you will, or scaled up telehealth capabilities across their networks. And so we'll talk a bit about early trends and some of the case studies. What I'd like to do at the outset, however, is introduce John. John's an incredible leader who's been really at the forefront of this movement to accountable care, having led the model that we're all here talking about today, the MSSP ACO model. John, we initially invited you to share a few words about the policy response for COVID-19, and in particular, some of the policies and guidance materials that you'd been putting out to ensure ACOs can do all that they can to keep their beneficiaries safe. But you did share some news last night. Your boss, the administrator, was kind enough to publish the results from 2019. And as a quick observer of the paper, very encouraging. And I think we'll have many more opportunities to dive deep on some of the details there. But John, I wanted to welcome you to say some opening remarks, and if you wish to comment about some of the success of the model, I'd welcome you to do that as well. So John, thank you for participating.
Thank you, Anish, and thank you for that introduction. And thank you all for the opportunity to come here today and give some brief introductory remarks and give you an update really on where some recent events, and including the results that got rolled out yesterday about the Medicare Shared Savings Program. And first and foremost, thanks for all the great work that you're doing across the country in your communities and responding to the pandemic. One of the things I like most about this job is to hear from our ACOs and clinical leaders across the country about how their organizations are responding, and how ACOs have actually provided a mechanism for them to, in some cases, more easily transition their physicians to telehealth, which I know is a topic that we'll hear about today as a result of the relationships that they've built after becoming an ACO with providers in their communities, as well as the relationships that they brought to their organizations that enable their success in the program. One of the things we did this summer in response to the rapid transition to telehealth was we issued some interim final rules that actually incorporated those telehealth billing codes into our assignment methodology in order to help mitigate the adverse impact of COVID-19 on ACOs assignment populations. So we incorporated these telehealth codes as a way to maintain that program alignment assignment between the patient populations that ACO providers serve. And we actually have proposals in the Medicare physician fee schedule rule to make those telehealth codes a permanent part of the program going forward, particularly if they're integrated and finalized as part of the larger Medicare program. We also this summer, to help mitigate the impact of COVID-19 on ACO benchmarks, is we finalized a policy to actually remove inpatient COVID-19 episodes from an ACO's performance year calculation as well as benchmarks, in order to mitigate any potential for undue losses, but also potential windfalls as a result of COVID-19 prevalence in their communities and so forth. And these were policies that were really in addition to our existing extreme and uncontrollable circumstance policies that mitigate ACO losses for the length of the public health emergency and provide additional relief and burden reduction around quality reporting. We also, I wanted to point out today, have policy proposals in the fee schedule to redesign the quality measurement methodology. One of the things I'll talk a little bit about is the promising results that we see continue to see on the quality side, but as a way to continue to raise the quality standards that ACOs have to meet to share in savings or avoid losses in the program. We're have policy proposals that would make the measure set more outcome oriented. It would significantly reduce reporting burden on ACOs, reducing the measure set from 23 to 7 measures overall, but reduce the number of measures ACOs have to report from 10 to 3. At the same time, making the measure set more outcome oriented. And again, we welcome your comments, thoughts and ideas as part of our rulemaking process, and we'll take those into account and do a thorough review of those comments as part of the rulemaking process before we finalize any policies. And then just to point out the news that was rolled out yesterday, the administrator's health affairs blog, that would encourage you all to review if you haven't. It includes our performance year 2019 results, which 2019 was an interesting year for us in terms of it was the transition year to Pathways to Success redesign. And that includes the first 6 months of those program results. And the changes that we made under the Pathways to Success final rule were intended to provide more accurate benchmarks and strengthen the overall incentive ACOs have to continue to reduce the growth in healthcare spending and improve quality, but also to continue to provide a robust incentive for new ACOs to join the program. And while they're the first 6 months of the program, the early results appear promising. Collectively, we had ACOs earning a total of $1.5 billion in shared savings payments in 2019. 55% of beneficiaries that received their care from an ACO were an ACO that shared in savings, which is one of the highest percentages we've seen under the program to date. And we also saw positive net savings under the program as well of almost of over $1.1 billion as well. The pathways policies that we finalized really kind of built on some trends that we saw early in the program, where risk-based ACOs perform better than our one-sided ACOs, and we can continue to see that under our pathways policies as well. And we also see low revenue ACOs, which can be more physician-centric, continue to outperform high revenue ACOs as well. And another thing I would point out is we saw both ACOs that renewed their participation in the program that have experience do well under the new pathways policies, but we also saw the new pathways ACOs that were new to the program for the first time perform equally as well. So we were encouraged by that. We continue to see trends with ACO sharing and savings to kind of look holistically across the continuum of Part A and Part B services. So we really sort of see lower spending sort of across the spectrum, or in a majority of those categories for ACOs that share in savings. And we continue to see ACOs continue to see ACOs have higher average performance, quality performance compared to other physician groups on similar preventive and chronic disease measures, as well as patient experience of care measures, as well as we continue to see over 90% of ACOs improve their performance on those measures year over year through earning quality improvement reward points under our scoring methodology. It's again early on in the program, but we're encouraged what we're seeing under those redesigned policies as well. So with that, I will turn it over back to Anish. Thank you.
Yeah, John, I thank you for your comments, and I will say, you have an understated style, which I appreciate and I respect, but I'm giddy. I think the results are strong. I think you are witnessing the maturity of the model and the transition, and really on a number of fronts, quality being just one. These are very, very exciting updates. So maybe I'll be the one a bit more enthusiastic today, John, in terms of maybe diving in. But kudos to you under the leadership. So thank you for your time. I know you have a busy schedule today, so please no challenges if we say goodbye. But we thank you for your time and greatly appreciate your leadership.
All right, thank you.
So with that, what I thought I might do is invite both Amy and Joe, colleagues at Yale and the VA, to share a bit about what motivated their initial research on identifying risk factors that drive COVID mortality. Obviously, early in the pandemic, there was a debate about how severe the virus is, how difficult it would be for folks to recover. And just as a personal note, the FDA convenes kind of a weekly open town hall, and Dr. Justice was a presenter earlier this spring and shared the results of her model. But caught my attention was that a version of the model could be run on CMS data, almost a pre-existing condition model, and it is what led us to today, her generosity in opening up the model and allowing not just us, but the public to benefit from that work. So Dr. Justice and Dr. King, can we just begin with a bit of context, please? What motivated the initial research inquiry, and maybe a little bit of a summary of the key findings, and then we'll dive into our work on the CMS side.
Thanks for the opportunity to talk about this with everybody. What what motivated this was simply that the VA and a number of other federal agencies have gotten together to try to look at COVID in a more systematic way, part of what was originally called the COVID's Insights Task Force, which was organized out of the National Security Council at the White House, to try to bring together data from multiple sources, beginning with the VA electronic health record data, since it's quite extensive, goes back more than 20 years and is a paperless chart on the national level. Early on, the Food and Drug Administration posed a series of questions to this group, asking for insights that the group might be able to offer. And one of the earliest questions was one around who is at risk should they get infected, and once infected, what are their likely outcomes? How can we predict their outcomes? So we thought it was helpful to target first the pre-existing condition question, quite honestly, in part because many people were already asking me these kinds of questions, both family members and past patients. How do I know how much risk I have? Is it only age? Are there other things that should be driving this? And of course, there was a lot of press about older people not doing as well. So we thought it was best to start with the question of, based on what people have before they get infected, can we predict who is going to have a bad outcome?
And then as close to non-technical terms as we possibly can, given the broad audience today, just roughly speaking, would you be so kind as to summarize some of the highlights of what you learned? I've tried to capture some of the variables that were driving the kind of predictive power of the background data set, but would you or Joe be so kind as to just walk us through your key findings?
Well, I would say that the most important finding is that at any age, comorbidity is still important until you get to very extreme ages, like more than 85 years of age. And that perhaps not surprisingly, the people who get to 85 tend to have lower Charlson comorbidity scores, so that there is an interaction, or you have to interpret the Charlson score, which is a summary of comorbid conditions, differently in somebody who's under 85 than in somebody who's over 85. But that really a relatively simple model based on data that's available in administrative data can give you a fairly accurate and reproducible assessment of risk. What you don't have on the slide, because we've only very recently done this, we've now validated this in 2 different prospective independent data sets from the VA, and actually the AUCs improved in the more recent data sets.
And I think the headline in my view, and we're going to get into the next couple of slides, is that in a sense, as we all grappled with responding to the pandemic, many of the ACOs on this call have pre-developed some form of risk model to ensure that their limited care management resources can be put to their highest and best use. I think the conclusion and the nature of what we're going to share now, we'll talk through together, might be that list can be supplemented for some of these factors that could inform a more effective response in the next phase. I've got a couple slides that I want to review with you and Joe, and we'll go through them sort of step by step. First, and the most obvious point, what we did generally find, and again, we're going to view this as observational data, not Care Journey is not running a peer-reviewed study yet on the outcomes. We are benefiting from an open data policy at CMS, where what was previously going to be maybe a 9-month to a year delay to get access to what happened in Q2 of this year is something that the CMS team has decided to make available immediately. So what we're seeing today are our attempts to run the pre-existing condition model on the full Medicare fee-for-service data with paid claims through July. That is obviously going to continuously improve with each monthly update, but it is as timely as one can get from the CMS administrative systems. And we did overlay the CDC's map of hotspots, for lack of a better term, and you can sort of see a little bit of the kind of the big point, which is the population of patients is expected to be greater than 30% mortality risk, and what was their COVID positive rate in each of these communities. And so we'll get into some of that in a detail in a moment, but what it means to say is, like you would expect, pretty significant variation in the size of this high risk group and the degree to which they've already experienced COVID. Let me now use this as the chance to get into some conversation with you and Joe. Folks, on the front end of this, if you took the variables out and said, for those individuals who are under the age of 85, but still, because of their comorbidities, at 30% or more mortality risk, that cohort is the smallest in the pyramid. It's about 431,000 Medicare fee-for-service patients. That is the kind of size group one could imagine applying care management resources to. There are a sizable number of 85 years of age and older, many of whom, because of their age, had high mortality risk as it was, and that is over 4.3 million beneficiaries. And then I think we missed the typo here on the bottom, but a much larger universe of beneficiaries, obviously with low mortality risk under the age of 85. And so that pyramid, if you will, reflects the kind of the distribution of the population. But Amy and Joe, this second pie chart is where I wanted to spend a couple of minutes, and that is the prevalence rate of COVID positive patients appears to be the highest in that under 85 but still high risk population. In other words, the very group I'm nervous about, the invisible high risk, not because of age, but because of other factors, is getting COVID at a higher rate than other Medicare beneficiaries. And sadly, your model of 30% mortality rate was in fact the actual mortality rate for these individuals by these categories. I just, more as a commentary on your end, really, than anything scientific in terms of methods, would you be so kind as just to share your reactions to this concept of, whether you're seeing a similar blind spot as a country on folks that are under 85 but have still high mortality risk?
Well, certainly the literature out there has emphasized older age, but what's considered older age has been variable, right? Some people consider anybody over 65 as old. And most of us who are approaching that age don't like to think that anybody over 65 is old.
Right.
So yes, I think that there's a lot of ambiguity in people's minds about what do we mean by older age and what does that risk look like. The other thing that I would point out is that a very large proportion of the people who are still employed are the younger age group. And they are individuals who need to have a better sense of what their risk is so that they can make appropriate decisions as things open up about whether to return to work or to continue to telecommute or what the best alternative is.
It's, I'm anxious personally, if there is in fact this blind spot, and I want to thank you for your contribution, I think being able to shine light on making sure people have the information they need. I mean, in a dream world, every Medicare patient that accesses the Medicare Blue Button service could have a simple calculator that says, let me run the VA's model on my phone to just sort of me or my loved ones more realistically to make sense for where they are, to make that incremental decision. Don't go out to eat even though your neighbors are, or what have you. I guess the last piece before I allow us to move to the panel is, again, early comment, just something to share. One of our members, Rush University Medical Center in Chicago, their research team has spent a lot of time on hospital quality, and an initial cut of mortality rates by star ratings, Medicare star ratings, again, early cut, but it does seem to suggest these one-star hospitals have a little bit of a higher mortality rate than the other hospitals, but they don't have any materially different prevalence you will, of risk category of patients. I wonder, Amy, are you thinking about the mortality risk as being a function of the therapy quality? Maybe if you get to the inpatient setting, is that an area that you're focused on, thinking about, reacting to?
Well, according to the questions that the FDA has put to this group, we are certainly beginning to tackle therapeutic questions. And we're seeing that as the rest of the country, the mortality rate has come down as groups have gotten more experience with managing folks with COVID, including the intubation rates. So certainly, as we have learned how to care for people, quality then certainly can act. And I think that it's only logical that that would be true.
So I guess my final opportunity or question for you is a bit more of a reflect. You've done this work, you've made the judgment to make it accessible. You have an audience of accountable care organizations who are organized for purpose of holistically caring for the patients in their purview. Any final thoughts, Amy, about what you encourage the group to do, not do, opportunities to further collaborate? I'd welcome any closing thoughts on your end about where we go next as a community.
Well, you and I have talked about the idea that groups might actually reach out, especially to those who might not recognize that they are at higher risk, but are in fact at higher risk, this group that you've identified, to give them some advice about what might be safe practices as things open up. I think that's certainly relevant. I live in Connecticut and things are certainly beginning to open up here. People are starting to talk about going back to work. So clearly, I think that's one domain. Another domain that I think deserves some careful thought is counseling people who are at just exceptionally high risk should they get COVID, that perhaps they want to think about going to a specialty hospital if they should have to be admitted rather than just going to their local hospital. There are a number of questions around, can we kind of advise people about what their level of risk is so that they can have a plan should they become infected, but also a plan to try to avoid getting infected in the first place.
No, I think that's exactly right. I am particularly anxious for the ACOs on this line to think about strategies to prevent and then strategies to refer where appropriate to centers of excellence. And so, Amy, we will certainly continue to stay in touch, and I greatly appreciate the work you've done, and I am confident we'll have more opportunities to collaborate. So thank you very much for your time this afternoon.
Okay, thank you.
I'm going to now turn to a little bit of a segue from the work we've seen Amy's team generate and what it has implications of for the ACO community. And I'm going to start with a couple of headline comments, and then I'm going to invite David and Raj to give us a few kind of on the ground insights from their respective ACOs. And so first and foremost, and I think this is maybe important to say at the front end, the mortality rate for individuals who are COVID positive is not materially different if you are an ACO enrollee or not. That is to say, on the question of if you've gotten COVID, what's your chances of mortality? However, the rate by which you may, your sort of COVID positive rate by cohort did see a material difference. ACOs, for whatever reason we'll talk about, had a lower rate of their highest risk, this blind category of 30% mortality risk or higher, but under the age of 85, that group that I felt appeared to be a bit blind in the overall, whether it be self-management or active management from their physician network. ACOs have found a way, it appears, to keep this group healthier and not contract COVID in the first place. Now, we'll get into that with Raj and with David, but one area that we are interested in exploring is the degree to which telehealth utilization differed. I can't say that it differed a ton, but you can see on the margin higher rates of beneficiaries using telehealth if enrolled in an ACO model in that very important cohort of 30% under age 85. And so we saw general utilization of telehealth, but slightly higher if you're in the ACO model, and much so, more so on the over 85 side. So with that, we have, because of that data set of claims through July, we do have a little bit of a window on the spike in telehealth utilization. The big headline for me, if you look at the Medicare population by cohort, the frail elderly, Professor Ashish Jha and his team at Harvard found had the highest proportion of avoidable spend, about 9% of the overall population. This is a group one was worried would not use telehealth. And yet here you see major complex chronic conditions, the disabled community and the frail elderly actually leading the pack in the share of that population accessing telehealth, which is a very positive sign. So I now want to turn, if I may, just as the, a little bit of a celebratory world, I'm going to start with David. We did rank the share of each ACO's population by the count of patients that are in this high risk group, under 85, over 30, to understand what their rate of telehealth utilization was. And Palm Beach ACO ran at the top of that list. Very broad success rate. So David, what I'm going to do is have you come in. You can see your fancy screenshot. I congratulate you on your youthful appearance, my friend. Let me begin with why and how. As I got into this, it looked like you went all in on telehealth. Could you just share a word about Palm Beach ACO's commitment to telehealth, and then we'll get into some of the more specific results.
Absolutely. Thank you so much for having me. Reminder, Palm Beach ACO is PCP owned and operated ACO in South Florida. And, reminding the clock back to March, it was a period of really great despair. So I sent you a picture, Anish, but several of our offices had completely closed. They had said, if you have symptoms, don't call, don't come in, go to the health department. And we had an extraordinary reaction. We felt like it was our personal responsibility not to abandon our patients, and then to give our PCPs all of the tools to effectively manage during this emergency. So we really seized the opportunity, and candidly, telehealth billing, documentation, and EMR, that was all areas of expertise that we had. And we just did an extraordinary effort to fix the issue. So as you can see on the screen, we did comprehensive turnkey consulting for our practices. We said, this is exactly how you bill, this is exactly how you document, and these are exactly the rules for telehealth. We provided them detailed technology consultation as far as the best tools by EMR. We had a full list of all 300 of our PCP practices, and then our employees, we're fortunate to have been in the program for a while, so we have 60 employees, but our employees were going through each practice to making sure that they were telehealth ready. And then finally, we gave a list of high-risk patients as well as low-risk patients. So obviously patients with comorbidities, respiratory issues, those are ones that need to be seen, but we were very concerned that the ones that were relatively healthy were being forgotten. So we also provided this secondary list of patients that we were very worried they weren't getting basic education. And then once again, we wanted to reiterate, your doctor is not abandoning you, and they are here for you. So please reach out if you need anything at all. And I'm glad to hear that the numbers were very high. That was our responsibility to fix, and it looks like we did okay.
And if I may, David, just to kind of peel the onion back a little bit, one of the areas that I had been keen to sort of surmise, if you will, a lot of practices were grateful for the easing of sort of these HIPAA burdens with respect to things like, I can't use my cell phone to provide telehealth to my patients. For years I've been scratching my head about this and wondering, what the implications were. Share a bit for the group. You sort of had the whole cadre of options. You obviously have a mobile app, which it's pretty cool that the ACO has a mobile app, but you also have a pretty wide, diverse range of EHRs in the community. I assume you went through the list of integrate with the EHR, standalone service. How does it link back to the work you're doing within the ACO? Could you just take us one layer below the surface on the implementation challenges. What did you see in terms of the diversity of the technology, and where did you ultimately land in terms of what worked the best that was scalable?
Absolutely, a short question. I'll do my best. All right, so we deal with physicians, and you always got to give them a menu of options. So especially as the rules became more broad, we shared the check-in and then the best use case for that. Obviously, you could message the patient, have a brief chat with the patient, and still bill for that service. And then we shared the full video conferencing capabilities, and then we recommended that significantly. We just felt like it would have the greatest intervention, connect with the patient the most. And then obviously the backup was a telephone. Ultimately we wanted to make sure that PCP access was available, and telephone was certainly a nice consolation. So we gave the variety, and then we pushed each physician to just choose from the menu. Just a epiphany for me was the EMR solutions were not widely adopted. We happen to have an EMR team that helps the offices with that, with their EMR management, which is very arduous. And we found that Doximity or Doxy.me on a smartphone, and then using the EHR, for the documentation, was the ideal scenario in almost all cases. So, if you do the telehealth through the EMR, you kind of lose a little bit of real estate, maybe, eat up some of the bandwidth. But we found that the smartphone in hand, computer on the EMR was the optimum platform. And we scaled that up to help our PCPs.
That's great, David. Last question, if I may. The last slide I have here does break down the high risk cohort by the age breakdown. I was struck by this blind spot of 30% mortality or greater, but under the age of 85. And yet, for whatever reason, they actually had more utilization in your model. I'm not suggesting that you had designed it to be that way, but my presumption would be, if you ran the VA's model against the model that you already have, would you imagine there'd be relatively similar patients? I wonder if that'd be an exercise worth running to see if running the VA model could complement or supplement your existing efforts to sort of shine light on what had appeared earlier as a blind spot for the country.
We always have room to improve as far as where we focus our interventions. I think I explained an approach that was rather broad, and it was kind of no patient left behind. But, after we accomplished that, it would have been nice to have been more focused. So yeah, I agree. Let's learn about the insights and, learn which patients were more actionable and more in need of an intervention.
David, thank you as always for your kind remarks and your continued success, and congratulations. Both you and Raj, as a good segue, were in the 2019 cohort of successful ACOs, and I'm congratulating you. And Raj, as we bring you in, I was struck by your CEO's commitment to embrace the kind of pathway to care delivery reform. I saw his piece in the Harvard Business Review, and a clear focus on both telemedicine and some very specific clinical interventions like hospital at home. Raj, would you be so kind as maybe just to say a few words, a little bit of context about Intermountain? Everyone knows Intermountain, but maybe a bit about your specific interest in some of these new models that are emerging. Take it away, Raj. And Raj, just check the mute button.
They just unmuted me. Sorry about that. Definitely, Anish. Look, this has been, as we think about our new care models, I think we need to ground ourselves on sort of Intermountain's long-standing path with telemedicine and digital health, and then I'll evolve this into how we moved into these new care models. But there's been over the last several years a deep foundation laid around sort of helping not only areas where Intermountain is, but rural communities with telehealth. So we have telehealth engagements from Montana to Arizona, really focusing on rural communities. We set up a virtual hospital system. We've launched a new digital front door called My Health Plus, et cetera. All of that pre-COVID. Post-COVID, COVID hit. Mark basically said, look, we're going to have to really think about new care models coming out of this. And as our EPI models showed a surge coming in Utah, our incident command center basically said, look, we have to move towards a hospital at home initiative. One, to really enable us to leverage that model to take care of COVID, sort of the lower acuity COVID members within the home. But two, as we think about business continuity and modernization coming out of this, because of the telehealth and digital foundation we laid, we were able to say this is going to be a service we're going to provide. So it's not just hospital at home, it's kidney care at home, home-based primary care, et cetera. So really establishing at-home services as not a adjacency to the core, but becoming part of the core. And COVID and some of the stats I'll go through really have accelerated our opportunity to move towards that new paradigm.
And that did take some leadership. I presume the economics for the hospital side of the business certainly were falling like they were everywhere else in the country. So this took some capital courage, you think? How would you describe the trade-offs for these new strategies that you were pioneering?
It does take capital courage. I will point out Intermountain's sort of top line revenue is around 45% risk, right? So if you think about that, the ACO is part of that as well. That gives us a platform to push these models. That said, there is still capital courage, if you will, to ensure that we're taking all aspects of the health system into account. We recognize, however, that that capital courage needs to be coupled with care model design courage. And so the combination of both, very thoughtfully thinking this through, but very rapidly deploying this, we're most proud of.
And we'll get into some of the impact in a moment. Just if I may, on the bigger picture, there are many on the line that are integrated delivery networks in some form or fashion. They're not at 45% risk. Is there a magical number in your mind, Raj, if you were to sort of guess a little bit, that you believe would give you enough business model justification for making some of these changes that frankly might adversely affect the hospital's P&L in the grand scheme of the model? Can you just share a little bit about, is there not that there's a magic number, but just for curiosity's sake, it's south of 45 and north of what?
Yeah, it's a great question. I would say I can give you a number kind of sort of anecdotally, and then give you more of a realistic approach, sort of thinking about product, because I would say most organizations maybe are on the higher end, 10 to 20%, if that. So I would say think about, if you're in that range, definitely begin to think about how, as you move more towards the risk continuum and more members and patients that fall under these risk-based models, to start thinking about care model evolution in that way. That said, those that are in an ACO model, for your ACO members, leveraging risk prediction methodology, what we just heard from the great speakers before, integrating that into your risk prediction methodology and setting this up product specific gives you a great start as you start to inch up towards 20-25%. So if you're taking some sort of risk in an ACO and taking some sort of risk on MA, you're taking risk on ACO, that is more than enough to start to consider these care models. We take risk on commercial, on exchange, on Medicaid, gives us a large platform to play against in terms of these care models. We don't see these care models as being limited, these new care models, to just the ACO or to Medicare Advantage, but they have the most benefit immediately in terms of those products.
Yeah, that's great. And in a similar vein, it did appear to us, whereas when you heard David talk about no beneficiary left behind, I thought that was an interesting anecdote. You had a very targeted focus. These that blind spot I described again, they were a higher proportion of your telehealth utilization population, and that's your statewide ACO. I'd be curious, just as your take on that. Was that because you had a kind of a targeted outreach, or walk me through a little bit about the methods that allowed you to be more, I guess, precise or focused in terms of who to make sure was cared for? That you somehow you lucked into picking the group of people that needed the help the most.
Yeah, it's probably a little bit of luck and a little bit of foresight. So we leveraged Castell, which is our sort of entity that bears risk for Intermountain and helps to manage the risk in a multi-payer, multi-product perspective, and really leveraged our risk prediction methodology and what we call our care traffic control team, which is doing proactive outreach based on that risk prediction methodology, which is updated in a real-time basis, essentially, and outreaching to these members to, one, connect them to services, and during COVID, reminding them or informing them about our telehealth connection. So if you think about our telehealth utilization as a system, year to date, we're at about for outpatient services and primary care, mostly around 210,000. Last year at this time, about 20,000. We've had over 1.3 million sort of tele/digital interactions, and a lot of that was the proactive outreach after identifying the risk cohort and letting them understand how to connect, when to connect, and the other options that are available for this cohort. We did get a lot of these members also into some of the newer care programs post that telehealth interaction. So I would say targeted effort. I think the luck comes in with, if you were to tell me what the penetration would be based on the outreach, I would have said it would have been lower. The surprise and the luck comes from the market and these individuals understanding during this time that there's a new model of care, that they can still be connected to their physicians and clinicians, and that meant a lot in terms of the rates that you see on the board.
Yeah, thank you for that, Raj. I think given your agile risk modeling, you may be among the first to give feedback to the VA on how incrementally accurate or effective it was in putting your resources to work. So thank you for that. Batting cleanup is Michael, my buddy from Precise Telehealth. This is an area that I've been keen to dive into in terms of all the range of possibilities. The word telehealth can obviously be applied to almost everything, from ongoing active patient monitoring to just traditional substitutable visits. Michael, I want to begin our discussion with my own personal take, which is, I was a champion for this thing called the White House Innovation Challenge for basically putting the CMS Innovation Center kind of assets to work on ideas sourced from the bottom up, not so much the top down. And the first graduate of that program was the YMCA Diabetes Prevention Program, which was nationally available in April of 2018 to any fee-for-service beneficiary. By the end of that year, as Politico noted, hundreds of thousands of people were expected to benefit. Obviously, in the first year, no one would think it would be that high, but the real number was only 202 patients were billed for the service. That's not a typo, that's 202. I think the same reality that there are opportunities to support patient care and the opportunity for remote patient monitoring, less than 0.5% of beneficiaries today are taking advantage of these capabilities. But Precise has a model where you're actually pretty active. You might actually be the dominant player in this area, if I may ask. So Michael, could you introduce the group a bit to what remote patient monitoring looks like and how Precise is engaging it for some of these high need, high cost patients?
Thank you, Anish. First of all, congratulations to the other panelists for their really tremendous work in applying telemedicine in an emergency situation. We at Precise Telehealth like to think of ourselves as the next generation application. What does this look like when we get out of the emergency and standardize the risk and the interactions between the caregivers and the patients in the home by using telemedicine? Our focus has been on 3+ to 5+ comorbid patients. We have worked primarily in a collaborative model so that the primary care physician or responsible specialist works with us. We then have optimized our practice to do telemedicine to the home, particularly for patients that are historically and apparently non-compliant, and then to apply those kinds of highly personalized, persistent, and qualified presence in those homes to help those patients overcome their disinclination to do the right activities to care for themselves and improve their quality of life and reduce their risk of hospitalizations and high costs.
And if I may, Michael, you've had some pretty impressive results. I thought maybe you could just walk the audience through a little bit about when you go after a population that is typically undermanaged, and maybe you could talk a bit about what your baseline perspective is on the folks that have 3 or more chronic conditions. But it does strike me that this ability to actively engage has some effect, and it could be a model for some of these high-risk patients that we want to keep safely at home, as we just outlined. Could you comment a bit about the baseline for this cohort and what you're seeing for those who benefit from this model?
Well, I think the most important element is that the primary care physician or the specialist stays engaged in the process and collaborates with us as a colleague. And so it's not just 3 conditions, it's 3 conditions in the judgment of the primary care physician or the responsible doctor that this patient is going to have trouble with their compliance and that they need some kind of intense, highly personalized outreach that will be persistent in their lives. For a lot of our patients, the problems include learning disabilities, physical isolation, patients that are recently widowed. You know, there's a lot of social and economic determinants that go into the level of risk that these patients have of being persistently complex and high cost. So the referral of the physician or the responsible specialist, the oncologist, the nephrologist, really becomes the important element in parsing the patients that belong in this kind of program.
And so this model does require that quarterback judgment. Have you given consideration or on the roadmap as CMS continues to open up the market for these services? Is this an area where you might go direct to consumer at some point, or does this model benefit from that integrated approach?
So I'm sure there will be companies that go direct to consumer. I think that our perspective has always been that when you alienate the patient or try and separate them from their high trust relationships with their primary care physicians or that specialist that's really taking care of them, that you weaken your relationship with the patient and you alienate the doctor who's responsible for maintaining that patient's well-being and the costs of their care. So for us, we'll always stay connected with the primary care doctors or specialists in a partnership, collaborating relationship rather than directly to consumer.
That's very helpful, Michael. Thank you for that. And I could probably go on another 15, 20 minutes with each of you guys today. I'm mindful of our clock. And so I want to thank the panelists for sharing with us a bit of the case studies and the opportunities. I do want to give Garrett a few minutes on the way in to just summarize where we are, but a quick update for our colleagues. As many of you know, the Robert Wood Johnson Care Journey participates in a program that's sponsored by the Robert Wood Johnson Foundation called Health Data for Action. We are working with the Healthcare Cost Institute, where we are gathering as much real-world data as is feasible to inform the country's understanding about the COVID population, the risk factors, and various what I would consider to be relatively straightforward tables of who are the patients that are admitted to the hospital and need additional services and struggle. And so we will be tracking many of these variables alongside a network of health systems and EHRs, data derived out of their EHRs. So stay tuned on the Health Data for Action research activities tied to COVID. Would obviously welcome anyone's feedback on that research agenda. I'm mindful that we ran over, so we didn't have a lot of dedicated time for Q&A, but my apologies. We will certainly do what we can to take questions if they are entered into the chat for subsequent follow-up. But with that, I think I will turn it to you, if I may, on our final comments, maybe about Garrett. I'll let you take it from here, the exhibit hall booth.
Great. Thank you, Anish, and thank you to all of our panelists. This was a very informative session, and thought that there was some really great information exchanged. Yes, to Anish's point, I wanted to encourage all of you as we conclude here to visit the Care Journey booth at ACOexhibithall.com, and then you can go here and you can learn more about them and connect with their team and interact there and look around as well in our archived library, where also is where this webinar will be housed. And to that matter, there will be a recording of the webinar and today's sessions and the slides, and I'm going to send all of you who have attended a link and registered, actually, if you had to drop off or weren't able to attend. I'm going to send you a link to where you can listen to the recording and where you can get the download for the slides and whatnot, and you'll find both of those again in the reference library here. But yeah, check out the Care Journey booth over at ACO Exhibit Hall. And lastly, if you guys have any specific questions for any of our panelists or the Care Journey team, and again, to Anish's point, we weren't able to do much of a Q&A today, but still definitely want to hear your questions. So please reach out to us. Here on the screen, you can see the info at carejourney.com. If you have a question for me at ACOexhibithall.com, there's my email as well. But thank you all for attending. I hope you found, again, today's presentation very informative and helpful, and hope you have a wonderful rest of your day. Thanks for coming.